Actually, my presentation will be about updates in controlled ovarian stimulation for ART. These will be the key points that we will discuss: major problems related with hyper-response to controlled ovarian stimulation, distinction among ovarian response and reserve, what is more appropriate, diagnosing a good reserver, diagnosing a potentially high responders, management of high responders. What about the basic assessment for having an individualized controlled ovarian stimulation? Should be done by basic ultrasound, day 2 or 3, hormonal profile, FSH, LH, AMH, and prolactin, besides CSH, E2. Assessment of BMI, mid-luteal, sometimes we may do mid-luteal phase serum progesterone, and for sure semen analysis should be done for the husband according to the WHO reference values. Concerning the characteristics for good marker, it should be with the lowest inter-cycle variability and the lowest intra-cycle variability, prediction of poor response, prediction of high response, applicable for all patients and economic. As you see here, the MH plus antifollicular count and age, these are the main factors and the main markers to judge who will be poor reserve and poor response, and who will be with hyper response or good response. Actually, this paper was published in Fertility Strategy 2015. Discussed comparison of anti-Mullerian hormone and antral follicular count as a predictor of ovarian response to controlled ovarian stimulation in good prognosis patient in individualized controlled ovarian stimulation. The conclusion was that when evaluating the data from 2 large multi-center trials at the study center level, the analysis showed that MH was a stronger predictor of ovarian response to gonadotropin therapy than antifollicular count. Within the majority of individual IVF clinics in both long and agonist and antagonist protocols. Anti-Mullerian hormone actually has variability during the cycle and during different persons. So it has inter-cycle variability and intra-cycle variability and inter-person variability. Initially, the MH variation observed during the cycle were considered as analytical variability. This was the start. It is true that different platforms will deliver different results depending on which molecular form of MH is being measured. Sample storage, freezing of sample, the assay protocol, and manual or automated method used. However, huge biological variations have been recently published that cannot be explained because of the analysis only. During the natural cycle, serum MH levels seem to be higher during the follicular phase than the luteal phase in women with normal, high, and low ovarian reserve. The total average of intra-individual MH variability in the ovarian cycle was 20%, and the biological variation was at least twice the analytical variations. Young women have a pattern of fluctuation intracycle that seems to be different in older women. Also, very short-term dynamics were described with circadian variation, and this is the new issue published by Bongam et al. 2015. There is somehow circadian variation in MH level. Short-term intercycle variations have been reported as well, probably caused by biological variation in number of MH producing follicles, similarly to the intercycle variations showed by the antifollicular count or the intercycle variations of ovarian response with same stimulation protocol. So we can notice that we are giving same stimulation protocol for the same patients in 2 different cycles with different response, okay? Or different antifollicular count in different cycles for the same person within short time, within 4, 5, 6 months. 4 AMH categories have been developed, but it is unclear what modeling underlies these thresholds, particularly AMH of 1.3 to 2.25 was used to classify normal responders, but in recent phase 2 and phase 3 randomized controlled trials, a poor response to ovarian stimulation was anticipated with AMH values ranging or lower than 2.1. Meta-analyses have several recent multicenter studies demonstrate that AMH exhibits an almost twofold higher correlation coefficient with oocyte yield than that observed for antral follicular count determined across multiple sites. What about obese infertile women? What about the level of AMH in these patients, in this category of patients? AMH levels tends to be increased in normal weight women compared to obese and overweight. Obesity may cause metabolism of AMH. Obesity could reduce the ovarian potential, and it may be related to ovarian dysfunction. What about the effect of obesity on fertility? There is negative impact on dose-response relationship between the high BMI category and consecutively increased time to pregnancy, especially in PCO patients. Lifestyle modification should be done to promote at least 7% weight loss for BMI higher than 30 by caloric restriction, meal replacement, weight loss, medications, and physical activities. What about the LH level in obese patients? Increased LH levels more common in lean and non-obese PCO women, secondary to an increase in the GnRH pulse generator and abnormal ovarian pituitary feedback. Rationale for preferring aromatase inhibitors in ovulation induction more than clomiphene citrate in obese and PCO patients. The aromatase inhibitor interferes with inappropriate estrogen feedback at the hypothalamus. Shorter half-life than clomiphene, less early pregnancy, exposure and cumulative effect, favorable reproductive effect, more monofollicular ovulation, and favorable endometrial effect. What about adjuvant treatment in obese patients, treatment and PCO obese patients, treatment with metformin in obese, especially if PCO, to lower the risk of hyperstimulation and unexpected ovarian response, decrease the insulin and LH secretion level, increased sex hormone binding globulin, and decreases androgens, total, free, testosterone, and androstenedione. We may give, personally, I'm not giving, but in the literature, it was mentioned that we may give glucocorticoids in women with dehydroepiandrosterone, more than 200 nanogram per deciliter. We may add dexamethasone, 0.5 milligram daily for from day 3 to day 12. Actually, this slide was presented in ASRM 2017 concerning the efficacy of ovarian stimulation. There are 3.5 times as many unstimulated cycles to achieve a live birth compared to stimulated cycles, and 2.9 times as many unstimulated cycles to achieve singleton live birth compared to stimulated IVF cycles. What is the right egg number? This is the frequency of the number of oocytes retrieved. In the vertical line, you will find the frequency. In the horizontal line, you will find the number of oocytes. As you can see here, the conclusion is that according to the HFEA, Human Fertilization and Embryology Authority data on all ART cycles performed in the UK between the period of 1991 and 2008, 70% of the cycles in the cohort of 400,000 stimulated fresh cycles with at least one oocyte retrieved had 4 to 15 oocytes. And this was presented by Sankara. This study presented by Sankara in 2011. As you can see here in the curve, the frequency, most of the cycles can give 4 to 15 oocytes. So most of the cycles in the UK, and it was thought that all over the world, most of patients will give from 4 to 15, the majority will give 4 to 15 oocytes. And these women probably represent the most common population included in clinical trials in the field of IVF. How normal is normal? Current evidence appears to provide a clear answer to the above query, with cumulative data from meta-analysis suggesting that the number of oocytes retrieved following ovarian stimulation is an independent predictor of pregnancy rates following IVF. Although the ideal number of oocytes had been subject of debate over the last few years, one of the earliest studies published in 2006 suggested that the optimal number of oocytes for maximal success was 15. But Verberg in 2009 had a different opinion. A meta-analysis published subsequently demonstrated that the optimal number of oocytes after conventional stimulation should be around 10, given that a lower number of oocytes resulted in detrimental effect on ongoing pregnancy rate, whereas higher oocytes yield did not result in any increase in pregnancy rate. Sorry. Okay, this is very famous slide, and always presented by my dear friend Sankara. She's one of the eminent scientists and speakers all over the world in the UK, and she presented this slide in SRM 2 years ago, and it shows the association between the number of eggs and the live birth rate in the huge study, which included more than 400,000 patients in UK. The analysis of EFRE registry, including nationwide collected data in the UK of more than 400,000 IVF cycles, suggested the ideal number of 15 oocytes, maximized live birth rate across all age groups. Based on this data, it would seem reasonable to define normal ovarian response as the retrieval of 10 to 15 oocytes following conventional stimulation. Women respond differently to controlled ovarian stimulation. Most often, the response is not predictable, especially if it is first treatment attempt. Prediction based on biomarkers may not always be accurate. Intrinsic factors that may play a role, particularly in the development of the major complication IVF, which is hyperstimulation, is not all known. Thus, controlled ovarian stimulation and the following events should be personalized, individualized. This is a very famous slide and very famous picture presented in many papers showing the ovarian stimulation, which is ovarian hyperstimulation, which is characterized by cystic enlargement, as you see, of the ovaries and rapid fluid shifts from the intravascular compartments to third space. Severe cases need hospitalization, and the prevalence is all over the world from 2 to 10%. HCG is the triggering factor. What about the risk factors for hyperstimulation? Low BMI, PCO, high doses of gonadotropins, agonists, long protocol, high E2, high MH, high antifollicular count, previous episodes of hyperstimulation, and pregnancy. Oocyte number as a predictor of hyperstimulation. As you can see the curves, the live birth rate on the vertical arm and the oocyte number on the horizontal arm, and the live birth rate is keeping ascending till the number of oocytes reach about something like 20 oocytes. Then you can see the curve. The curve will start flattening. The curve of the live birth rate will start flattening, and then it will start dropping after 20 oocytes, while the curve of the hyperstimulation will start increasing more and more, starting from 15, 20 oocytes and higher number of oocytes. What about the impact of controlled ovarian stimulation on the endometrium? There is a histological approach, noise criteria, acceleration, which is acceleration of the endometrial maturation, overcooking, immunohistochemical approach, modification of the steroid receptors profile, protein profile, endometrial secretions, the changes, endometrial gene expressions, which is the epigenetic changes, methylation and demethylation, and which will be modified in the controlled ovarian stimulation cycles. What about the IVF in women with PCO? What are the pros and cons of PCO? The pros for this category of patients, the pros that they are younger, they can give better ovarian reserve and response, higher pregnancy rates, but the cons, they have increased risk of hyperstimulation, increased rates of pregnancy loss, increased maternal complications, preeclampsia and others. IVF in women with PCO, hyperestimulation is the most serious iatrogenic complication in IVF. Polycystic ovarian syndrome is a major risk factor for hyperestimulation. 63% of severe cases of hyperestimulation occurs with PCO, 7 to 18% hyperestimulation after fresh embryo transfer, compared with only 2% in general IVF population. Okay, what about the reproductive sequelae of PCO, endocrine and metabolic sequelae containing metabolic dysfunction, subfertility, ovulatory defects, oocyte quality, implantation defects. There is also changes in the miscarriage rate in PCO women. Some papers mention that there is an increase in miscarriage rate in IVFs, in stimulated IVF cycles. What about the metabolic abnormalities? PCO women have greater hyperinsulinemia and insulin resistance than weight-matched controls. Insulin resistance independent of effect of obesity. Insulin augments androgen response to LH. Insulin suppresses sex hormone binding globulin. Potential mechanism of impaired implantation in PCO. The impaired implantation may happen due to altered estrogen environment seen with anovulation and obesity, overexpression of androgen receptors, no downregulation of estradiol receptors, potential negative impact of low progesterone associated with anovulation. What about the low prognosis patient? Why patients may demonstrate a suboptimal response to ovarian stimulation? Genetic variation could be a reasonable explanation of reduced ovarian sensitivity to stimulated and suboptimal response in this population, which we can call premature ovarian insufficiency. Several research groups have examined the effect of specific single nucleotide polymorphism in the FSH receptors, besides the beta subunit gene of LH, gene changes and gene mutations of the LH, and demonstrated that specific single nucleotide polymorphism may be associated with altered response to ovarian stimulation. Very famous picture. Most of us saw it in many papers, in many presentations, and it showed the modified definition and judgment of the poor response and differentiation between the poor response and the poor reserve, as it categorized the patient into 4 groups, which first of all, they called it Poseidon criteria or Poseidon classification. As you can see here, they classified patients into 4 groups: first, second, third, fourth. First and second with MH higher than 1.2 and intrafollicular count more than 5, equal or more than 5, and category 1 with young age group, category 2 older age group, elder than 35. Category 3 and 4, the reverse, MH lower than 1.2 and intrafollicular count lower than 5, with the 2 age groups. Now, Poseidon introduced the concept of low prognosis in ART, combined oocyte quality and quantity for identification and the stratification of the low prognosis patients, included high responders as a distinct category of low prognosis patients. Actually, this is a nice paper published in Human Reproduction in 2015. about the suboptimal responders following controlled ovarian stimulation. The conclusion was it is increasingly accepted that individualized controlled ovarian stimulation offers such women the best chances of success with minimal risks following IVF treatment. The starting point, however, is to fit an individual woman into a particular ovarian response category in order to tailor the stimulation protocol and interventions. Another nice paper published in 2018, a recent one, discussed individualized controlled ovarian stimulation in expected poor responders. And according to the Poseidon management, Poseidon classification, they decided that the management for category 3 and 4 who are poor reservoir will be managed by giving them, as you see in the slide, a long GnRH protocol or antagonist protocol with a stimulation with 300 international unit recombinant FSH, pre-treatment with androgen or not. This is a query. Embryo transfer will be done fresh or frozen. Frozen, sure, by embryo accumulation will be much better for this category of patients. Measure of success for category 3, which is, if you remember, patients younger than 35, okay, is to give 4 to 7 oocytes at least to obtain 1 euploid blastocyst. What about category 4? This paper discussed that in category 4, almost the regimen of treatment and the protocol will be almost the same, with giving 300 international unit recombinant FSH, either long agonist or antagonist, and fresh or embryo accumulation by freezing embryo transfer, by frozen embryo transfer. But the measure of success in this category is to give at least 12 oocytes, which will be needed to obtain only 1 euploid blastocyst. So I think from my viewpoint is that embryo accumulation is a must for this category of patients who are elder than 35 and have poor reserve MH lower than 1.2 and intrafollicular count lower than 5 oocytes. What about the individualized triggering and in embryo transfer and embryo transfer? What is the role of FSH surge? FSH surge actually promotes nuclear maturation, the resumption of meiosis, induce LH receptor formation in utilizing granulosa cells. What about LH? It helps in sensitive of many factors and cytokines, steroidogenesis, activation of uterine LH receptors, implantation. What do commonly we do today regarding triggering? Trigger the final oocyte maturation with HCG or recombinant HCG, large bolus of 5,000 or to 10,000 international unit HCG, induce the ovulatory process, stimulate the endogenous progesterone from multiple corporal lutea, increased risk of hyperstimulation. How can we play around the HCG triggering? Adjustment of dose according to the ovarian response. How low can we go in the HCG dose? A dose as low as 3,300 international unit was effective in inducing oocyte maturation. 2,500 unit was effective in PCO women, but 2,000 units was ineffective. Triggering with agonist in antagonist protocol started in, as you see here, in 1973, and many updates already have happened and have introduced till approving the protocol in 2000, okay, with the use of single bolus of GnRH agonist triptorelin to trigger ovulation after GnRH antagonist treatment in women undergoing ovarian stimulation for assisted reproduction. GnRH triggering for all or only hyperresponders. This is main question, and from my viewpoint, if we will feel that this patient will start hyper respond or to give large number of follicles, we should think about agonist trigger and think about freezing of all embryos, or as an alternative, if the patient insisted to do fresh transfer, we can try dual trigger by giving a small bolus of HCG on the day of triggers, or a small bolus of HCG on the day of pickup, or lastly, small bolus of HCG, or maybe on day 5 and day 1 and day 5 post pickup. Otherwise, we should give intensive luteal steroid rescue if the patient insisted to have fresh transfer after agonist trigger by estradiol patches, progesterone, especially the high dose of intramuscular progesterone and high dose vaginal progesterone. Agonist trigger, what is the best approach? Repeated question, freeze all or not? Okay, summary, ovulation trigger should be individualized in the hyper-responders. GnRH agonist trigger with a freeze-all strategy will almost practically eliminate all hyperstimulation. Luteal phase support in agonist trigger cycles should be supported either with HCG or intensive administration of steroids. The effectiveness of agonist trigger and frozen embryos mean that overstimulation is now much less of concern than understimulation. AMH and antireceptor count are the effective predictors of ovarian response. Varying FSH dosage has little effect once the cycle has started. Clinics should have standardized protocol for agonist trigger administration. Number of oocytes retrieved is an important prognostic variable in IVF. Nonlinear association between oocyte number and live birth rate in fresh IVF. High cumulative live birth rate with increasing oocyte number. Increased risk of hyperstimulation with oocyte number equal or higher than 20. Understanding association between ovarian reserve, oocyte retrieved, and IVF outcome is important for planning individualized ovarian stimulation. Lastly, gonadotropin dose 225 international units for normal responders and 150 for high responders. Basically, there is no benefits from gonadotropin dose higher than 300. Long GnRH agonist or antagonist protocols for poor responders, GnRH antagonist protocol for PCO or higher responders, intensive luteal phase support with agonist trigger in fresh autologous cycles.